The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everyone. This is Sarah Na from ICAAP. Thank you so much for joining us tonight for the faculty training for reaching our goals. We're going to get started here in a couple of seconds. What we're going to do, just to give you a heads up, is I'm going to do a little bit of housekeeping, and then I'm going to turn it over to Anita Chandra, who is going to be running through the 2014 presentation for you. And then at the end, we should have a little bit of time for any questions or comments that you may have. So what I will also do is I'm going to mute everybody on the line just in case you're traveling or there are any sort of background noises. So if you have any questions that you'd like to be answered, or if you're having technical issues or the audio isn't great, you can type them into the questions box, which is located in that dashboard to the right-hand side of your screen. And I can go ahead and address those as they come up without interfering with the actual presentation. So what we'll do is, I know a couple of folks are going to be joining us later this evening. They're running a little bit late or we're coming directly from work. So we'll go ahead and take roll and introductions at the end of the webinar. If you have to jump off for whatever reason, I do have a record that you were here at the beginning, and all of this will be recorded and the information will be sent along to you within the next 2 days before the end of this week. So just to let you know, for 2014, I know we got a little bit of a late start in doing some of these presentations, but the project plans call for doing 6 rural county immunization summits in Winnebago, St. Clair, Cook County, Carterville, and Macon. We're going to be doing office-based trainings to Chicago VFC providers, and the main difference this year is going to be those Chicago VFC provider office-based visits will focus more on the 0 to 3 years of age, whereas the rural county immunization summits or presentations will be more IDPH focused and will focus on 0 to 18 years of age for immunizations. We have a bunch of webinars that are coming up this spring and summer, which hopefully all of you have been getting emails about in terms of registering or helping us to promote the events. They also can all be found on our website if you ever need a refresher about when they are, how to access that information. So following today's presentation, at the end, like I said, it is recorded, and you will be able to have access to the recording following tonight's presentation. I also will send everybody an individual email with a couple of housekeeping items that you will need to fill out and return to me prior to starting the presentations. So just an updated W-9, making sure that your bio is up to date, those sorts of things. So without further ado, what I'm going to do is turn it over to Anita Chandra. So for those of you who don't know, Anita received her medical degree from Northwestern University School of Medicine and conducted her residency at Children's Memorial Hospital in Chicago. She currently practices pediatric medicine at the Northwestern Memorial Physicians Group and serves as an instructor in clinical pediatrics at Northwestern University School of Medicine. She is board certified in pediatrics and is a fellow of the American Academy of Pediatrics. So with that being said, I'm going to go ahead and turn it over to Anita.
Hi, everybody. Despite all of those lovely credentials, I'm trying to make sure that I can get the screen the way it should be. Because for some reason, it is not showing the big screen.
There you go.
That's my set of slides. That's not the. That's not your set of slides.
Do you want them to see my set of slides?
Sure. Or I can start mine. It's fine. Whatever works.
Let's
do that.
Does
that work for everybody?
Perfect.
Okay. So this is our Reaching Our Goals immunization provider education, and my understanding is that all of you have in the past had some exposure to the Reaching Our Goals program, and so this is really going to be a refresher in terms of what we'll be doing this year. There are a couple of things to point out along the way, but we'll kind of go through these slides fairly briefly. If you have questions, I'd love to be able to answer them afterwards. and we'll just kind of go through this step by step. Okay, so this is brought to you, of course, by the Illinois and Chicago Departments of Public Health through the Immunization Initiatives Project at the Illinois chapter of the AAP. And we're going to be talking about the immunization schedule for 2014, how to improve immunization coverage in our preschool and adolescent population. We're going to briefly talk about the school requirements for this year, touch points on preventing HPV disease, general strategies to improve immunization practices, and then a little bit on vaccine safety and administration. So the immunization schedule of 2014 is endorsed by the CDC, the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Obstetrics and Gynecology. And there are some key footnotes, basically, to pay attention to. We've all seen the change in the 2014 schedule since it's been out already for a while. And really the focus of it is that the schedule combines all age groups into one schedule with specific details in the footnotes, which will be helpful if there's questions about the different vaccine products that are licensed. The yellow brackets represent the range of recommended ages for all children. The green brackets recommend the range of recommended ages for catch-up. And purple is the range of recommended ages for certain high-risk groups. And so it's just important to be able to follow these along. And then there are footnotes at the bottom of this that will really be helpful specifically for the meningitis vaccine product. There's also clarification in the catch-up schedule for Haemophilus influenza type B, pneumococcal conjugate vaccine, and the Tdap vaccine. And so this, if you're not familiar with it, is the catch-up immunization schedule. And I think when you're talking to the different practices as you're giving this presentation, it's important to just point out some of the changes. I think a lot of practicing physicians have difficulty remembering the nuances of the Haemophilus vaccine and the pneumococcal vaccine. And there's been so much about the Tdap vaccine that it's just always good to review with them the specific catch-up issues, if there are any, in their own practices. Also, and I already said this, but there are footnotes for each vaccine related to routine vaccination, catch-up vaccination, vaccination of persons with high-risk medical conditions. Yeah, I think just basically kind of going through the vaccine schedule and the catch-up schedule in some detail with the groups that you're presenting to will be helpful. There's guidance on the 2014 schedule as well for the influenza vaccine in terms of the scheduling for 6 months through 8 years for the 2013-2014 season, which is past now, and the upcoming 2014-2015 season. There's also opportunities to talk to the groups that you're with about the offerings that the CDC has to help them if they have websites. There are programs go through the CDC along with healthychildren.org that you might be able to point them towards for updating their own websites if that's helpful or if that's something that they're interested in. So if we talk about improving preschool immunization coverage, this slide has been available to us for a while, and it is a wonderful slide to point out to the practices that you're presenting at just about the amazing importance of vaccines. In this day and age when there's so many people who seem to be doubting the value of vaccines and trying to come up with alternative schedules, it's really, really important to point this out so that the physicians that you are presenting to feel like they have something to back up what they say to their patients. I feel like I'm sort of preaching to the choir here. You guys know what we're talking about, but it's really making sure to point these things out to the practices you're presenting to. And then this is a nice slide to sort of remind them of the actual visual of what some of these illnesses are that we've been able to take care of so well with vaccines: measles, pertussis, Hib, periorbital cellulitis, and then pneumococcal pneumonia, which doesn't have a visual other than a child needing oxygen. So kind of going along with the fact that people are doubting the value of vaccines, it's important to point out the recent measles activity in the United States. In 2013, there were nearly 200 cases in the United States. The majority of these cases were travel-related, so many cases were among those with philosophical exemptions. And then in 2014, we've already seen a couple of large outbreaks in New York City, 20 cases, and in Orange County, California, there were 35 cases reported. And these importations came from the Philippines or Europe. So again, travel-related in illness, another thing for your audiences to be able to understand and talk about with their patients. So here's a nice little graph or nice little picture. What did Hannah bring back from vacation? A T-shirt, a snow globe, and measles. So it's always good to remind them about the fact that vaccine-preventable diseases are still out there, and they should never become complacent about vaccinating their patients. In terms of the MMR vaccine recommendations, for the routine vaccination, the first dose of MMR vaccine is given at 12 to 15 months. The second dose can be given 4 weeks later, is usually given before the start of kindergarten at 4 to 6 years of age. For international travelers, though, it's really important to note that infants as young as 6 months can receive their first dose of the MMR vaccine. In the United States, the only vaccine available is the combination MMR. This vaccine does not count as their official 1-year-old MMR vaccine, and so then they'll still, after they turn 1, need to receive 2 doses of vaccine separated by at least 28 days, and non-immune adolescents or adults need to get 2 doses of the measles, of the MMR vaccine separated by at least 28 days as well. This graph depicts pertussis cases from 1922 to 2013, and if you look at the early part of the 1900s, there were the incidence or the number of cases of pertussis were topping 200,000. When the DTP vaccine was licensed in 1946, we were seeing roughly 100,000 cases of pertussis annually, and there was a beautiful decline in pertussis cases after the use of the DTP vaccine. But then again, in 1995, there was a change. We switched over to the acellular pertussis vaccine, and there was a subsequent rise to the fact that in 2011, I think it was 2012, I think this data comes up later, there were over 40,000 cases of pertussis again. And, you know, physicians have asked me in the past, why do we think this is? And I think it's a multifactorial thing to point out to them that there's a natural pattern to pertussis illness. So there's natural variations in pertussis illness. There may be something to do with the decreased efficacy of the acellular product. There may be a lot more to do with the fact that there are pockets of people who chose not to immunize. There's natural variability or natural loss of immunity over time, and so we really pushed over the past couple of years to get adolescents re-immunized. So hopefully this increase is now coming down, but this is a nice graph to show how bad it was at one point in time. And if we look in 2012, yeah, I think the data that I have was 48,000 cases of pertussis in 2012, of which there were 20 deaths reported, the majority of which were under 3 months of age. But the largest age groups that seem to have been affected by pertussis cases were infants, then the 7 to 10-year age group, and then 13 to 14-year-olds. But in 2013, fortunately, there were more states that reported a decrease in pertussis cases than an increase. So I think that that speaks to the fact that we really push to have pertussis vaccination as a booster in the adolescent time period, as well as with adults and new parents and older individuals. So in terms of the vaccine recommendations, to refresh your audience, DTAP is licensed through 6 years of age. It's given as a primary series at 2 months, 4 months, 6 months, and then 15 to 18 months of age. The booster dose is given between 4 to 6 years of age. And then Tdap is recommended now as a single dose at this point in time. The Boostrix product, which is GSK's product, is given to 10 years of age and older, and the Adacel product, or the Sanofi Pasteur product, is licensed for 11 to 64 years of age. It's recommended routinely at 11 to 12 years of age, with catch-up at 13 to 18 if not received at 11 to 12. And then children, of course, 7 to 10 years of age who are not fully vaccinated with DTAP would be getting the Tdap dosing. And this is actually a requirement in the state of Illinois to have their Tdap vaccine when entering 6th grade, and we'll certainly talk about more of those full requirements later. The Hib vaccine schedule, it's recommended to administer a 2 or 3 dose Hib vaccine in the primary series at 2 months, 4 months, and 6 months, and this would be the ACT-Hib, the Menhibrix product, or Pentacell. PDVax-Hib or COMVAX are administered as 2 doses at 2 and 4 months of age, with a dose at age 6 months not indicated with those products. And then a booster dose is recommended at age 12 through 15 months. And the exception, or the thing to point out here, is just that the Hibrix product should only be used as a booster dose in somebody who's already received 1 prior dose of a Hib-containing vaccine. I believe that the individuals who use the different RAX products will know this, but it's good to remind them that for the most part the Hib vaccines are interchangeable, but this specific product can only be given as a booster or final dose. And the pneumococcal conjugate vaccine schedule, the routine vaccination schedule with PCV13, which is really all that is around, is a 4-dose series, 2 months, 4 months, 6 months, and then again, I should say 12 through 15 months, sorry. And then for children 14 through 59 months who have received an age-appropriate series of the 7-valent PCV7 for some reason from another country, let's say, then you would administer a single supplemental dose of the 13-valent PCV13. And then catch-up vaccination with PCV13, when you'd administer 1 dose of PCV13 to all healthy children aged 24 through 59 months of age who are not completely vaccinated for their age. Again, you'd have to really reference the catch-up schedule to help your audience, we leave both the 2014 schedule as well as the catch-up schedule with the offices that we are presenting to, so that's always helpful to them. So if we look at our immunization coverage report card in the preschool years, we are not doing very well. And this is why specifically I think the CDPH, or Chicago Department of Public Health, really wants to focus in on the 0 to 3-year-olds. If you look at our Healthy People 2020 target of 90%, which is a sort of a mathematical determination of what would be the ideal coverage rate to decrease incidence of illness, we fall shy of it for everything, really, for 4 doses of DTaP, for Hib, for PCV13, and for 1+ doses of MMR. So there's room to really push and remind people that they need to keep up with these vaccines even in this young age. I think we've kind of come full circle almost, where we really did such a good job of talking about immunizing adolescents for so many different things that we kind of didn't push the younger, or what we consider the routine childhood immunizations as well. So we really want to keep pushing and making sure that we don't fall short of our goals here and risk of resurgence of a lot of these illnesses in our community. I'm going to go back to this slide for just a second. This data was obtained through telephone calls and surveys to households where they were able to contact them about immunization, and they were verified by physicians as well. The 2012 survey population is really more reflective of the U.S. population based upon the fact that those were more cell phone-only households, and that definitely shows that coverage levels have decreased, as we said, for all of the 4 vaccines mentioned earlier. And so what are some of the challenges with the booster doses? Just lack of awareness that boosters are needed. Sometimes we have infrequent healthcare visits after a year of age. There's always the situation where there's missed opportunities by clinic staff, and we want to make sure we're not missing those. So you want to talk to your audience at these presentations about making sure that they administer all vaccines that are necessary at each visit, that they create reminders for the clinic staff, whether they're color-coded stickers or hopefully more people are using electronic records, using standing orders for the nurses or medical assistants to help make sure vaccines are up to date. And then, of course, there's a huge push to use ICAAP, which helps to track immunizations and automatically will generate reminder recall programs to patients who are missing doses, and they generate letters that can be sent out to these patients about their missing vaccines. In addition, the ICAAP program also generates school physical forms and separate immunization records if that's what's needed. It's nice from a tracking perspective because coverage level reports are generated, and VFC vaccine management reports are also generated, which is really helpful with this whole process of VFC usage. So this is what a school health form would look like populated by ICAAP, and this is nice to show to the audience that you have just about this is one of the benefits of ICAAP in case they are not already registered with ICAAP or don't already use ICAAP. And then this is what a patient immunization report looks like, which just hones in on the immunizations specifically. It also, in the bottom left-hand corner, shows you shots that are overdue, shots that are due later, and then any invalid shots might be caught as well at the bottom. So, does your child meet the new immunization requirements? So we're going to talk about adolescent coverage. When do physicians most commonly check their immunization status? 95% of the time they check at all health maintenance visits. Only 42% of patients have their charts reviewed during illness visits and about 50% during follow-up visits. So people clearly do what they're supposed to do at the health maintenance visits, but the problem is that how often do adolescents come in for health maintenance visits? Once a year at best. At best, really, I mean, oftentimes they only come in entering high school, and then when they get a letter from school saying that they're missing something. So the reasons we want to keep talking to our audience about why adolescent immunization is crucial is because obviously we know from a medical standpoint that it prevents long-term sequelae of various vaccine-preventable illnesses like cervical cancer from HPV and cirrhosis of the liver from hepatitis B, and then meningitis complications. The more we make sure our adolescents are immunized, we have a greater herd immunity to protect others who don't get immunized. At this point, when adolescents are still under parental insurance coverage or VSC programs or college health services, it's really nice to be able to get the adolescents in. We all know that adolescent time period is a time of new environments and riskier behaviors potentially, travel, and just the fact that they often don't come in because they have so many other conflicting or conflicts time-wise. This is a time of potentially more experimentation in patients, which is why it's important to get them in not only for their vaccines but also for good health guidance. And then we want to be able to capitalize on physician trust that's developed over time with them while they're still under our care. If we talk about school requirements, students in Illinois in the 2014-2015 year, students entering 6th through 12th grades will have to show proof of a single dose of TDAP, and unvaccinated students can be excluded from school. Acceptable documentation would include a note from the healthcare provider with the TDAP and date administered, or an electronic medical record printout with the TDAP and date administered, or a current certificate of child health examination form with the TDAP and date administered. And this is going to be checked for all 6th through 12th graders now. Additionally, in terms of the varicella vaccine requirements for this upcoming school year, students entering kindergarten, 6th, and 9th grade must show proof of having received 2 doses of varicella vaccine. The first dose, of course, is given on or after the first birthday. The second dose, and this is a point that I was able to research earlier today with Sarah's help, the second dose is recommended to be given 3 months after the first dose if under the age of 13, or 4 weeks after the first dose if after the age of 13. Proof of prior varicella disease would suffice if there's a physician-diagnosed varicella documentation, or if the healthcare provider interprets a description of varicella that is indicative of past infection and documents that, or if there's laboratory evidence of varicella immunity. So this is a new thing for this year, that 2 doses of varicella vaccine. And then the meningococcal conjugate vaccine requirements in Illinois will be for the 2015-16 year. But again, if you're getting your adolescent patients in now, it's important to be able to give them what they need. The students entering 6th grade will be required to show proof of having received 1 dose of the meningococcal conjugate vaccine. And then students entering 12th grade will be required to show proof of having received 2 doses of the meningococcal conjugate vaccine. Of course, if the first dose is administered at 16 years of old, or the second dose is not required. So this is a requirement. The meningococcal vaccine requirement is for 2015-2016, but it's being put out there now so that if patients are at the physician's offices and if the physicians know that this is a requirement, they will start to catch them up and vaccinate them appropriately. This is a IDPH immunization code that school nurses can be looking through. This can also be available to the providers to make sure that they understand which vaccines are required at each different level, and it tells you the minimum dosing and proof of immunity for each of the different vaccines. Again, not something to memorize, but something to show them. Exemptions in the state of Illinois, if any of you have been reading or hearing about this, there's an increasing number of exemptions in the state of Illinois, and we're working on trying to break down what the cause of this is and how to decrease the exemptions. In Illinois, medical exemptions are when parents or legal guardians have to submit a document indicating the medical condition which was endorsed or signed by the physician on the Certificate of Child Health Examination form. So that is allowed in the state as obviously a medical exemption. Philosophical or just moral exemptions are not allowed. However, religious exemptions are allowed in the state of Illinois, and this is when a parent or a legal guardian presents to the local school authority a signed statement of objection detailing the grounds for the objection, and the objection must set forth the specific religious belief that conflicts with the exam, immunization, or other medical intervention. The medical and religious exemptions are allowed in the state of Illinois. However, philosophical and just generally moral exemptions are not allowed. Now if we switch gears to preventing HPV disease, I'm going to skip through this. This is a video actually, but I don't think we'll be able to show it through this format. You'll probably be able to show it at your Reaching Our Goals presentation, or I hope you'll be able to show it at the Reaching Our Goals presentation. So in terms of talking about the HPV infection, we want to make sure we mention that this is the #1 sexually transmitted illness in the United States. It is a fact that almost all females and males will be infected with HPV at some point in their lives. There are 14 million new infections per year in the United States. And HPV infection is most common in people in their teens and early 20s. I've been asked before why that is, and I think it has, what I found is that it has more to do with the character of the epithelium of the cervix in the younger age group, which makes it more susceptible to the HPV infection. Unfortunately, most people will never know that they have been infected unless they have an HPV positive test or pap smear, and unfortunately that may be too late for them, and certainly they can spread it to others because they don't even realize that they've been infected. HPV exposure can occur with any type of intimate sexual contact. Intercourse is not necessary to become infected, and it's important that we point that out to the providers that we're presenting to. Nearly 50% of high school students have already engaged in sexual, vaginal, penile intercourse. These numbers are always startling, that a third of 9th graders have engaged in sexual intercourse, and 2/3 of 12th graders, a quarter of whom have had 4 or more partners by the time they're in 12th grade. This is a graph that shows acquisition of HPV disease after sexual debut. It's a cumulative graph that shows the incidence of HPV infection by month subsequent to the first intercourse, and so by 2 years, nearly 40% of females in college who have become sexually active will have contracted HPV infection, and in roughly 24 months or 2 years, more than 60% of males who are sexually active will have become infected with HPV. So it really, it's a startling and very upsetting number. The average number of new HPV-associated cancers by sex in the United States, this graph shows from 2005 to 2009, an average annual incidence. In women, there are over 20,000 cases of HPV-associated cancers annually. In men, there's 12,000 cases. The most common type in women is cervical cancer. The most common type in men is oropharyngeal cancer. And these numbers, of course, don't even account, or this graph doesn't even show you the over 1.4 or so million patients who suffer from cervical disease or pre-invasive cervical cancers, or the 40,000 patients who have high-grade anal, vaginal, or vulvar precancerous changes. HPV infection accounts for 90% of the anal and cervical cancers out there, and 50% of the vaginal, vulvar, and penile cancers out there. So this just shows you sort of the timeline of HPV vaccine recommendation. In 2006, the HPV-4, which is the Gardasil product, was recommended at 11 to 12 years of age or 13 to 26 years if not previously vaccinated for females. And then in 2009, the HPV-2 product, which is Cervarix, was recommended for that same group of females, but the HPV-4 vaccine was permissibly recommended to 9 to 26-year-old males. And then in 2012, males were given a more green light go-ahead recommendation, again with the HPV-4 product. And where we stand today in 2014, females HPV-2 and HPV-4 are recommended 11 to 12 years of age or 13 to 26 years if not previously vaccinated. And with males, again, HPV-4 is fully recommended at 11 to 12 years of age or 13 to 21 years if not previously vaccinated, or at 22 to 26-year-olds for high-risk populations. 8 years later, what do we know about the effectiveness and the safety of the HPV vaccine? HPV infections have decreased in the United States from 2007 to 2010, proof that it works. In 14 to 19-year-olds, vaccine-type HPV prevalence has decreased from 11.5% to 5.1%. Other age groups didn't show a statistically significant difference over time, which would be expected as other age groups were not the age groups given the vaccine. The research showed that vaccine effectiveness for prevention of infection was an estimated 82%, which those are great numbers to point out to your audience so they can talk to their patients about this. The incidence of genital warts has gone down, again, in the 15 to 19 age group, along with the 20 to 24 age group, with the onset of usage of the vaccine in 2006. And this graph shows you the decrease in genital warts among females less than 26 years of age in Australia from 2004 to 2010. I think the important thing about this slide is just to understand that in Australia there's an 80% vaccination rate for the HPV vaccine, and there's really been a dramatic decrease in genital warts and HPV infection. HPV vaccines are safe. Nearly 60 million doses have been distributed in the United States since 2006. Nearly 180 million have been used worldwide. The most common adverse events were mild, soreness at the site locally, fevers, but in terms of serious adverse effects or events, no unusual patterns that occurred that would suggest the events were caused by the HPV vaccine, which is very reassuring. The findings are similar to the safety data of the meningitis vaccine and the Tdap vaccine. So if we look at our report card in terms of coverage, Australia, like I mentioned, about 80% coverage, the UK 83%, Canada 69%, Netherlands 50%, the United States all the way down to 32%. Interestingly, I find this sort of just interesting. In Rwanda, there was a very big project to get all teenage girls vaccinated. It was a mandatory sort of school-based project, and there was I think a 93% coverage rate of the population with the vaccine, and a very similar number in terms of decreased rate of genital warts as well in the population. So we know that the vaccine works. We just have to get it into our patients. If you look at this map, in Illinois, we are not in a very good category in terms of our coverage rates. In Chicago, we're a little bit higher than the whole state of Illinois, but that's really, I mean, so we can say we have about 60% coverage in many places in Chicago, but that also still means that there's 40% of our patients that are not covered. So it's interesting. California, Nebraska, Vermont, Massachusetts, Rhode Island, Delaware have the highest coverage rates. Very scattered areas of coverage, but it's important to keep pushing for our teenagers and young adults to be vaccinated. If we look at vaccine coverage rates or vaccine coverage rates in the United States, Tdap is approaching our healthy people goal. Meningitis vaccine is a little less, one HPV vaccine dose in girls is higher than all 3 in girls, is higher than 1 in boys, is higher than all 3 in boys. So it's not necessarily just that it's a 3-part series that makes us concerned. There just isn't the same coverage rate of HPV vaccine as there is for other adolescent vaccines. And why is that? I think maybe because it's just been so sensationalized by the popular media to be associated with sexuality instead of cancer prevention. I think a lot of clinicians aren't necessarily getting a very strong recommendation about the vaccine. I think the phasing in between girls and then boys was confusing to parents and maybe seemed like it was much more of an elective thing. So we're going to talk in the next few slides about different ways to make it so that our providers are really getting this vaccine across to their patients. We want to make sure that the physicians are giving very strong recommendations about the vaccine. We want to make sure that they're starting the conversation early and focusing on cancer prevention as opposed to any real discussion about sexuality. Sometimes, if possible, it helps to offer a personal story about HPV or suffering from cancer in any way that they know of that maybe will bring to light the reason for this vaccine. It's always important to have open discussions with the parents, especially about the safety, which hopefully we've given the providers some more safety details, and then to remind the providers to screen immunization status at every visit. The next couple of slides all have to do with different ways that providers can talk to their patients and their parents about the vaccine. And I think that probably of all the slides, this is the most important thing, is that providers should be listing the HPV vaccine along with the meningitis vaccine, along with the Tdap vaccine. It should just be a simple recommendation across the board as opposed to, I recommend this, and oh, we can offer you this. The message should really be, you're here for your adolescent vaccines. I recommend the meningitis vaccine, the Tdap vaccine, and the HPV vaccine, all at the same level of recommendation. And then there are various slides here about different ways to say this, which I think that when you're presenting for the individual offices, you'll have a chance to have more of a discussion with the providers about what kinds of feedback or negative feedback they're getting about the vaccine. There's always the question about whether or not the vaccine increases promiscuity or increases sexual activity, and studies have shown that there has been no difference in markers of sexual activity since the usage of the vaccine. There's no increase in pregnancies or decrease in pregnancies. There's no increase in counseling on contraceptives because of the HPV vaccine. There's no difference in the markers for testing for diagnosis of sexually transmitted infections, unrelated to HPV specifically. So I think you can tell your audience to tell their parents that the HPV vaccine does not make their child more sexually active. These are, again, those slides about different ways to say the same thing to their patients. Strategies to improve immunization rates: strongly recommend vaccines to parents and patients, screen immunization status at every opportunity, establish provider reminders, whether they're electronic systems or stickers, implement standing orders, give all shots needed at one visit, increase access to vaccination services, remind them again about weekend service clinics or evening clinics. It's important for the providers to be knowledgeable about the financial assistance available for adolescent vaccines through the VFC program or the health department vaccination programs, the FQHCs, and there are some pharmaceutical company patient assist programs as well. In terms of vaccine administration, these are slides that you probably have all seen. Make sure you talk about appropriate needle lengths, not pre-drawing the vaccine, ensuring proper transport and storage, minimizing vaccine loss and wastage through appropriate inventory management, including an emergency plan for storage, and accurately documenting vaccine administration. Remind them about the 4 true contraindications, that an anaphylactic reaction to a vaccine or vaccine component, encephalopathy less than a week after a prior dose of pertussis-containing vaccine. The severely immunocompromised patient is contraindicated in terms of getting live viral vaccines only, and pregnancy is a contraindication for live virus vaccines only. There are some other contraindications for the live attenuated flu mist vaccine, which you need to go into if that's what they carry or use in their office. False contraindications, mild illness, low-grade fever, antibiotics, premature birth, except for the Hep B, which needs to be given after 2 kilos, after a child attains 2 kilo weight. Stable neurological condition, mild to moderate local reactions, or an immunocompromised family member or close contact. None of those are contraindications to receiving vaccines. Remind them of the 3 different types of adverse reactions: local, systemic, allergic, and always talk to them about how screening is the most effective method of prevention. Our priorities, really maintaining high preschool and adolescent immunization coverage levels. In the Chicago Reaching Our Goals programs, we'll be talking really a lot about the preschool age group, and then of course throughout Illinois about the adolescent age group as well, keeping up with the new school requirements, and then focusing in on preventing HPV-related cancers. I think those are your priorities. So I'm open to questions or any discussion.
Thank you so much, Anita, for that presentation. That was great. I know that there was a lot of information covered in sort of a short period of time. So is there anybody who has any questions at this time for Anita, either regarding the content of the information or sort of the program in general? You can go ahead and either raise your hand or you can type your questions into, like I said, that question box over on the right-hand side of your screen. And we can go ahead and start to answer those. Kimberly, it looks like you might have a question. So what I'm going to go ahead and do is unmute you, and you can go ahead and ask your question right now. Kimberly, are you there? So it looks like Kimberly has self-muted herself, which is great. I appreciate it. But that means we won't be able to hear you. So Kimberly, if you want to go ahead and ask a question that you had, you can go ahead and let me know when you've unmuted yourself, or you can type your question into the question box. So it doesn't look like anybody has any questions, which is great. It doesn't mean that questions won't necessarily arise. So what I will advise to everyone is once you have a chance to look through the information yourself, perhaps listen to the presentation again. If you do have questions as you're going through it and preparing for your presentations, please feel free to reach out to myself or anybody else at ICAAP if you need something answered or you'd like some guidance, and we can go ahead and assist you. Like I said, following today's presentation, we will send you some information or ask for you to fill out a couple of forms to get you up to speed in order to deliver the presentations this year. So just keep an eye out for an email from me regarding that information. And as always, if you have any questions, please don't hesitate to reach out. Otherwise, thanks again for, oh wait, we have a question. Sorry, of course, saved by the bell. Okay, so we have a question from Jelaine Lapke. I apologize if I am not pronouncing your name correctly. And the question is there more on vaccine safety or the numbers of refusers? So we do have a little bit more information on vaccine safety, which I can send you a couple of extra slides from previous presentations if you think that that would be helpful. I can send that in a separate slide deck, and you can sort of intersperse that information as you see necessary. And then in terms of number of refusers, are you asking if there's data on people who are refusing vaccines? Okay, so I'm sure what we can do is, I know that sorry, that's my toddler.